Good evening, friends. This is Dr. Rajkumar. On behalf of Vadodara Psychiatric Society, I welcome you all on this ECME, Brain on Wednesdays. And the topic today is new treatment paradigm of positive symptoms, the apparent resistant cases, as well as what we are missing in all cases. To throw light on this and navigate our way through, I call upon Bhaskar. We all know him. Bhaskar, the platform is yours.
Hello everyone. Sorry for the initial hiccup, but as people say, ये छोटा छोटा इशू रहता ही है बड़ी बड़ी देश में. So let's go on with the meeting. First, in this talk, I would slowly talk about what we discussed in the go forward, and we would go forward into real pathology, real action of medicines, and then if there is time, we would go into some specific questions, or the specific questions would be for next day. The specific questions are: is clozapine the original drug and the exact drug? The specific question would be: how justified is to actually trust on observation of a 40-year-old trial? Then would come: is there any molecule that can be called the best molecule, or it would always be a combination and other thing? But this would be the last part, because first we need to navigate and need to understand. Once we understand, we can actually create our own regime. So with this, let's start the whole thing. I'm sharing my screen, and I would just stop my video. That would make it easier to navigate. So this is today's topic: treatment of positive symptoms based on molecular psychopharmacology. Antipsychotic, clozapine, and the dopamine hypothesis, they would be questioned today. But first, a slight revision and what last episode means. This was what we understood in last episode, that delusion is formed by increased autobiographical processes, high extended motivational or reward circuit tone, and decreased inhibitory control and decreased executive function. These three combine to form fixed firm belief, not amenable to logical reasoning and delusion. But each of them in isolation produces three other effects. Increased autobiographical processes lead to rumination and obsession. High extended motivational or reward circuit tone leads to compulsive and impulsive behavior. Decreased inhibitory control and decreased executive function leads to attention deficit trait and addiction to process and substances. So this is the disorder of autobiographical processes. There comes, this is the network actually, a network that extends from insula to temporoparietal junction to anteromedial prefrontal cortex to premotor cortex to posterior and posterior cingulate cortex and various other areas. This is the network for rumination and obsession. Now, disorders of extended reward or motivation circuit. This leads to compulsive and impulsive behavior. This is a large network that connects dorsolateral prefrontal cortex, orbital prefrontal cortex, temporal pole, hippocampus, anterior insula, ventromedial prefrontal cortex, nucleus accumbens, anterior thalamus, and amygdala. You can see it is a huge circuit, and its disturbance gives rise to impulsive and compulsive behavior. Then disorders of executive circuit, which actually is a flexible hub between motor network, auditory network, visual network, and it is known as variously by 9 names, amongst which 5 actually are existent and 4 are not so. So this is another large circuit which gives rise to attention deficit state, addiction to process and substance. And now comes the inhibitory control. Inhibitory control is combined motor and cognitive circuit, which starts in various areas of cerebellum, includes dentate nucleus, thalamus, motor cortex, supplementary motor cortex, premotor cortex, then prefrontal cortex, and ultimately create possibly the largest brain circuit which inhibit the motor action as well as behavioral action as well as cognitive thing part. And disorder of this circuit leads to attention deficit state, addiction to process and substances. So these are the 3 large networks which gives rise to delusion in totality and in isolation, rumination, attention deficit, and compulsive impulsive behavior, and various addictions. Now, this is the flow chart of hallucination formation. All delusion forming machinery plus disturbed sensory discrimination network, disturbed sensory integration network, this resulting in disturbed spatial perception and orientation, giving rise to hallucinations of all sensory modalities, though auditory is primary because auditory is less amenable to cross checks and balance. Now, the sensory integration network is a large network which would involve all the sensory input channels plus thalamus plus hippocampus plus cerebellum plus various areas of cerebral cortex. We don't know the exact pathways of cerebral cortex that give rise to sensory integration, but disturbed sensory integration network gives rise to 2 things. One is disturbed spatial perception and orientation, but the other thing is sensory processing disorder. And you know, sensory processing disorder as something that is common in autism spectrum symptom. So this is where psychosis and autism spectrum disorder merge. And this is how actually more and more patients whom we diagnose as treatment resistant schizophrenia and blah, 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 they are actually high functioning autism or autism spectrum who are ultimately developing the full disorders of sensory integration and ultimately producing psychosis. In the initial stage, there are sensory modulation disorder, sensory based motor disorder, sensory discrimination disorder. Anyone who is in touch with child psychiatry knows this name by heart, and I am not going into the details of this. Now, disorders of sensory discrimination network. Sensory discrimination is again a huge network which has various arms in cerebellum, then all the special senses, then posterior parietal cortex, then primary motor area, premotor area, supplementary motor area, then thalamus, then hippocampus, then superior calculus, then that goes into various parts of temporal cortex and dorsolateral prefrontal cortex, ventral medial cortex. This gives rise to this disturbed when they are disturbed, they give rise to disturbed sensory integration network, which causes disturbed spatial perception and hallucination on one side, and other side is again sensory processing disorder. This child of autism who has sensory processing disorder may very well grow to be so-called treatment-resistant schizophrenia of tomorrow. And the people who are never going to go in past history of the patient or childhood history of the patient or birth history of the patient would never be able to find the hidden high functioning autism symptom. So we so far discussed about connectomics formula, the connectomic pathophysiology of psychosis. It gave us various ideas, it gave us various insights. But does knowing this connectomic formula gives any help in psychopharmacology? No. Connectomic knowledge is for something else. It is not for psychopharmacology. Because knowing this electrical grid would not tell us how the electrical grid is being formed, how the electrical grid is being disturbed molecular way, and how the specific hubs and nodes produces specific macro level functions and dysfunction. Drugs are non-specific. Actually, this is blessed way in most of the ways and cursed in occasional ways. Why it is blessed? Because drugs do not consider it is only problem of brain. Drugs consider it is problem of whole organism. So they treat the whole organism. They don't focus on brain and lose the other areas. That give rise to better care, better cure. And problem of drugs is they are non-specific, so they are not expected to work on one specific thing. They would work as a whole. They work at molecular levels, affecting brain-wide function and systemic function all over our bodies. So what was the point of last time's discussion? Because this last 15 minutes and 1.5 hours of last discussion was on only connectomics. So why we did that if that has no help in psychopharmacology? Here we actually learned the connectomics pathology behind the real phenomena that we see in our day-to-day clinical practice. And now we don't have to give patients imaginary psychological formula. We can directly say that, look, your executive system is control is not working, so you are having this kind of hallucination. Or we can give the family explanation that, look, the motivational circuit is working overtime, and that is why in addition to the psychosis there is also impulsive compulsive behavior and the person is going into drinking and other thing. We can also do various back calculation. For example, we can understand that why alcoholic hallucinations occur, because alcoholism is actually one of the expressions of impulsive compulsive behavior, and During chronic alcohol withdrawal, what would happen is the executive circuits would go down, the inhibitory control would go down, and that would give rise to excessive visual and auditory imagery, and ultimately that would come as hallucination. So we can get understanding of various phenomenology through the connectomics formula. We might not be able to predict the treatment through connectomics formula, specifically the pharmacological treatment, but we can get the clear conceptual explanation for a lot of things that we see in our day-to-day clinical practice. And we actually got new and novel targets of electrical, magnetic, ultrasonic, and infrared radiation stimulation of various brain symptoms in this discussion, including new indication. And actually, those who are interested in neuromodulation, they would find following few slides very interesting. What novel areas we got? Insular cortex for sensory processing disorder. Insular cortex for somatic symptom. Insular cortex for various forms of impulsive compulsive problem, specifically that concerns various bodily symptoms. Temporoparietal junction, posterior cingulate cortex, medial prefrontal cortex. Medial prefrontal cortex is not so novel, but the use of medial prefrontal cortex in this way is novel. Temporal pole, various areas of cerebellum, which is now getting prominence. Posterior parietal cortex, these would be the novel areas where we can give RTMS, we can give deep TMS. Insular cortex is better accessed by deep TMS. Posterior cingulate cortex by deep TMS. Medial prefrontal cortex by either deep TMS or normal RTMS. Cerebellum areas, some areas would be amenable to deep TMS, some areas would be amenable to RTMS. Posterior parietal cortex, better to be given by deep TMS. And a novel indication, nobody has told that autism spectrum symptoms would be amenable to the various neuromodulation. Attention deficit symptoms would be amenable to various neuromodulation. Impulsive compulsive symptoms would be amenable to neuromodulation. Negative symptoms would be amenable to neuromodulation. Executive functioning failure in various so-called neurodegenerative disorders would also be actually amenable to various neuromodulation. And in neurorehabilitation process, we use neuromodulation mostly on aphasia. But with this understanding, we can see that neurorehabilitation process needs a lot of neuromodulation in various areas of brain for revival of various sensory and motor deficits. So the question, what we did in today's 20 to 25 minutes and last time's 1.5 hours, we actually learned useful pathological explanation, pathophysiological explanation, and we learned where to give various neuromodulation in various brain dysfunctions, and that is where our conceptions come handy. Now, what about medication? Because most, if not all, are psychopharmacologists first, and in anything else later. Medications work at molecular neurobiology, molecular biology level, and affect everything in cellular function all over body. Medications don't discriminate. So to know their actual action, we need to know the basics of molecular neuroscience of brain activity. Speaking of which, brain is not an alphabet soup filled with 7 letters. That is the biggest mistake psychiatry is doing for last 70 years. We talk about dopamine, serotonin, glutamine or glutamate, and noradrenaline, these monoamines. These 4 monoamines. Then we talk about endopioid, endocannabinoid, that too recently, and we talk about GABA. That is the end of our neurotransmitter understanding. We forget that brain has close to 2000 neurotransmitters, also known as cell-to-cell transmission, who have their autocrine function, dastacrine function, paracrine function, endocrine function. There is no scope for brain to have just 7 neurotransmitters. All world view of psychiatry is through 5 and now 7 neurotransmitters, which almost does everything in brain according to psychiatry. They do not. So we need to readjust our reality. It's time we wake up to 2024 rather than in 1960. This is an example. See, dopamine transporter is mostly concentrated in basal ganglia. But if you look here, where is the pointer? Yes. If you look here, there is dopamine transporter. If you look here, there is some dopamine transmitter. If you look these areas, there are dopamine transmitter. Yes, this is the main concentration, but actually dopamine transporter is distributed throughout the brain. Serotonin transporter, it is the whole brain, midbrain, and basal ganglia has more concentration, but it is whole brain. Noradrenaline, same. So our this view of this neurotransmitter is working on this circuit only. This has to change. Every circuit has at least 1,000 neurotransmitters. So our drugs don't work via neurotransmitter. Either that is the reality, or our knowledge of brain so far is very wrong.